Pharmacology 3, Unit 1, covers neuro and tegumentary, eye and ear. In Unit 1, we're covering the chapters 6, 10, 11, 19, and throughout every unit, we'll always dip into chapters 20. Terminology will be covered in every one of these chapters, so make sure that you review terminology in every chapter. The terminology is more covered in your pre-exams versus in your exams. However, you may also see some terminology in your exams, not to say that you won't. The central nervous system functions. The central nervous system, the CNS, consists of the brain and the spinal cord. The nerves coming from the spinal cord are part of the peripheral nervous system, the PNS, and are controlled by the brain. The PNS nerves serves to relay signals between the brain and the body by connecting the CNS to organs, limbs, muscles, blood, vessels, and glands. The CNS has many critical structures and actions that work together to ensure continued normal whole body functioning. The brain monitors and regulates the coordination of body system and activity, including movement, endocrine secretion, and intellectual functions, such as thinking and decision-making. It monitors body conditions by receiving sensory information from elsewhere in the body and from the environment through vision, hearing, smell, taste, spatial awareness, and touch. The brain interprets this information and determines how the body should respond. For example, we actually see with our brain, not our eyes. The nerve endings of specialized photoreceptor cells, the rods and cones, in the retina detect and convert light into signals that are then sent through the optic nerve to the brain. The brain translates the light signals into what we see or perceive. Altered perception is how optical illusions work. Magicians create illusions by taking advantage of how our brains interpret stimuli. Many problems that occur inside or outside the CNS can affect the brain function. This chapter focuses on drug therapy for CNS problems that mainly affect physical function, including Parkinson's disease, known as PD, Alzheimer's disease, known as AD, epilepsy and multiple sclerosis, known as MS. Drug therapy for problems that primarily affect behavior and mental health is covered in chapters 11. Movement is an important motor function that involves the brain, spinal cord, nerves, muscles, and bones. For example, your decision to deliberately move your arm starts when you think about it, which excites nerve cells, neurons, in a particular part of the brain. Initial excitation is turned into an electrical signal that causes your muscles to move the arm in the direction you planned. Getting the signal from your brain to your arm muscle involves a relay of signals known as conduction through a specific line of connected nerves. At each connection, signals are conducted across an intervening space called a synapse. The transmission of electrical impulses between neurons depends on the release of neurotransmitters. Neurotransmitters is a chemical that is released from the end of one nerve, crosses a synaptic cleft, and then binds to receptors on the next nerve in the line. This action transmits the electrical signal that started in your brain through the line of connected nerves. When the last nerve in the line gets to your arm muscle, the neurotransmitter binds to receptors on the muscle and triggers the muscle contraction needed to make your arm move. Neurotransmitters can be excitatory or inhibitory. Excitatory neurotransmitters include acetylcholine, also known as ACH, epinephrine, and norepinephrine. When the excitatory neurotransmitters, ACH, is released from the end of a nerve in response to thinking about moving your arm, it ensures that the action signal gets transmitted to the next nerve in the line. At that point, where the last nerve in the line is stimulated, the ACH it releases binds to receptors on the arm's skeletal muscles, and they contract and move your arm as you intended. Inhibitory neurotransmitters include dopamine. Sometimes some types of serotonin and gamma-butyric acid, also known as GABA. Smooth movement requires input from excitatory neurotransmitter and an inhibitory neurotransmitter, dopamine. These inputs are balanced in such a way that when you decide to move your arm, you can control the direction and degree and strength of the movement. You do not need the same strength to rub your eye gently as you do to throw a baseball 60 feet. Without dopamine to modify arm muscle contractions, your arm movement would be fast, jerky, and wild. Think of how much hot coffee you would spill moving a cup to your mouth if dopamine were not modifying this arm movement. Some problems that occur in the CNS, such as Parkinson's disease, result from an imbalance of excitatory and inhibitory neurotransmitters. Other problems, such as epilepsy, are caused by conditions in the brain that allow neurons to become excited when the excitation is not needed. Still others, such as Alzheimer's disease and multiple sclerosis, result from degenerative changes that occur in nerves or the support cells of the brain. Some problems that occur in the CNS, such as PD, result from an imbalance of excitatory and inhibitory neurotransmitters. Other problems, such as epilepsy, are caused by conditions in the brain that allow neurons to become excited when the excitation is not needed. Still others, such as Alzheimer's disease and multiple sclerosis, result from degenerative changes that occur in nerves or the support cells of the brain. Second, only Alzheimer's disease and Parkinson's disease is the most common neurodegenerative disease. The exact cause of PD is unknown, but it is thought to be caused by a combination of genetic, protective, and environmental factors. The incidence of PD increases with age, but it can occur before the age of 50 years. The disease strikes more men than women. The diagnosis of PD takes quite a while because there is no specific test for the disease. Diagnosis is made after all other neurological disease processes have been ruled out. The disease manifests as movement disorders and is associated with the presence of Lewy bodies in the brain. Lewy bodies are protein deposits in the brain cells associated with thinking, movement, and memory, and they cause dementia. If cognitive problems occur a year or more after the movement difficulties begin, the patient is said to have Parkinson's disease dementia. Drugs for Parkinson's disease. PD is a CNS disorder in which not enough dopamine is available to modify excitatory signals to skeletal muscles. Dopamine is an inhibitory neurotransmitter that is mostly produced deep in the midbrain area, known as the substantia nigra, which is part of the basal ganglia. When this brain area slows or stops production of dopamine, the balance between excitatory motor nerve signals and inhibitory motor nerve signals is reduced, causing mostly excitatory input. Movements become hard to control and jerky, and some muscles are rigid because they fail to relax sufficiently. When the arms and legs move, they catch at certain points in a stop-and-go fashion known as cogwheel rigidity. The neurological problems also cause facial features to become mask-like. The gait becomes slow and shuffling with short steps. The risk of falls greatly increases. Other common symptoms of PD include tremors, stooped posture, difficulty stopping motion after it has started, and difficulty chewing and swallowing and drooling. Depression, hallucinations, anxiety, and delusions are frequent complications of PD. Delusions and hallucinations can result from the changes in the brain that PD causes, or they can occur from the adverse effects of PD drugs themselves. The PD drugs increase the dopamine levels to improve the motor symptoms, but unfortunately, increasing the dopamine supply can also cause hallucinations and delusions. Symptoms of PD worsen over time until the patient eventually requires total care. Box 10.1 in this chapter lists the motor and non-motor symptoms of PD. The motor symptoms are slow movements known as bradykinesia, decreased arm swinging when walking, difficulty rising from a chair or turning in bed, absence of facial expression, instability when standing up, freezing in place and having a rigid stance, stooped, shuffling gait, and tremors. The non-motor symptoms are constipation, diminished smell or sense of smell, depression, anxiety, and irritability, problems with focused attention and planning, slowing of thought, language, and memory difficulties, personality changes, dementia, hallucinations and delusions, sleep disturbances, urinary frequency. Although drug therapy does not cure PD, it can delay worsening of symptoms and allow patients to remain independent longer. Drug therapy for PD includes dopamine and dopamine agonist, catechol methyltransferase, also known as COMT inhibitors, and monoamine oxidase type B, MAOB inhibitors. The common drugs in these classes are listed in your book on table 10.1. A dopamine agonist is a drug that has the same chemical structure as natural dopamine and is used to increase the levels of dopamine in the brain to restore balance between the actions of acetylcholine and dopamine. The therapeutic effect of these drugs helps reduce muscle tremors and rigidity and restore balance between the actions of acetylcholine and dopamine. The therapeutic effect of these drugs helps reduce muscle tremors and rigidity, improves mobility, muscular coordination, performance. Dopamine agonists can be used alone or as symptoms progress. They can be used in combination. The National Parkinson's Foundation recommends that carbidopa-levodopa, known as Seniment, Rytary, be used as a first-line treatment for patients with PD who are older than 70 years of age, and that the newer dopamine agonists, such as pramipexole, known as Mirapex, ropinirole, known as Requip XL, and rotogotine, known as Neurapro, be used as first-line treatment in patients between the ages of 50 and 70 years. All patients will eventually require levodopa because dopamine becomes deficient in PD. Levodopa is synthesized in the brain and converted to natural dopamine. For this reason, levodopa is the most important drug used to manage the symptoms of PD. Carbidopa is usually given in combination with levodopa because it allows more levodopa to get into the brain cells. This means that lower doses of levodopa can be used, preventing the nausea and vomiting that accompanies the continually increasing levodopa doses needed to control disease symptoms. Levodopa, levodopa, is rarely given alone for this reason. Wearing off is an issue of a drug losing its effectiveness. It can occur after levodopa has been used for several years. The action of levodopa peaks about an hour after administration and wears off in 4 to 5 hours. The wearing off effect causes rapid swings of symptoms. Symptoms improve when adequate levels of dopamine are present and worsen as the amount of dopamine decreases and its therapeutic effect wears off. This is also called an on-off effect. The extended release form of carbidopa-levodopa and the longer half-lives of dopamine agonists help to prevent this effect. Carbidopa-levodopa is also available in an intestinal infusion pump, Duopo. The pump is inserted directly into the small intestines through a small feeding tube and can deliver 16 continuous hours of carbidopa and levodopa therapy to reduce motor symptoms. The nursing implications: carbidopa-levodopa tablets come in different dosages and are increased frequently, from 3 times daily up to 5 times daily according to improvement of symptoms. Tablets also come in extended release form. Extended release tablets are scored. Do not crush or chew whole or half tablets. They must be swallowed intact. Extended release forms of tablets that are not scored should not be halved, crushed, or chewed, or retained the slow release effect. Give 6 to 8 ounces of water at least 30 to 60 minutes before eating to maximize absorption. Give with a non-protein snack to avoid nausea. Do not give with high-protein foods because they decrease absorption. Instruct patients to get up slowly to avoid postural hypotension with all dopamine agonists. Monitor blood glucose levels closely in diabetic patients to avoid hypoglycemia caused by increased sympathetic tone. Closely monitor patients with a history of cardiac disease for hypotension and increasing dysrhythmias. Monitor liver function study because these drugs are metabolized in the liver and monitor complete blood counts because these drugs can increase the risk of GI bleeding. Notify the healthcare provider about any behavioral changes, hallucinations, or delusions. Monitor for worsening dyskinesia and/or dystonia reactions and notify the healthcare provider if they occur because this can indicate a need for dosage change. Skin reactions are common with the use of NeuroPro patch. Do not apply the patch in the same place more than once every 14 days, and after removing the patch, gently clean the skin with mild soap and water. The most common side effects of carbidopa, levodopa, and all dopamine agonists include postural and general hypotension, headache, GI disturbances, insomnia, dream abnormalities, decreased impulse control, and confusion. The most common adverse reaction to carbidopa-levodopa is dyskinesia, which results in involuntary muscle movements that look like uncoordinated dance movements. Dyskinesia is common in patients on long-term carbidopa-levodopa therapy, longer than 3 years. The effect of dyskinesia is minimized with the use of pramipexole, ropinirole, rotogotine, and other dopamine agonists. Dopamine agonists can also cause delirium, a distressed state of mind that causes irrational beliefs characterized by illusions and paranoia, psychosis, and hallucinations. If these problems occur, the healthcare provider needs to determine whether the symptoms are related to the advancing disease process, depression, or the PD drug. The drug interactions, use of antihypertensive agents with dopamine agonists can cause severe hypotension. Use of older non-selective MAOI inhibitors such as Nardel, known as phenolazine, along with dopamine agonists, can precipitate a hypertensive crisis. Phenytoin dilantin reduces the effectiveness of dopamine agonists. Multivitamins that contain iron decrease the effects of carbidopa-levodopa. Vitamin B6 increases the metabolism of levodopa, taken without carbidopa. Metoclopramide, Reglan, can reduce the effectiveness of dopamine agonists because of the metoclopramide is a dopamine agonist that prevents dopamine from combining with dopamine receptors. The use of dopamine agonists with sedatives worsens drowsiness and increases the risk of confusion, hallucinations, and delusions, especially in those already suffering from mental illness. Long-term use of dopamine agonists may lead to akinesia, loss of movement, tardive dyskinesia, abnormal and involuntary movements, especially of the lower face, and dystonia, impairment of muscle tone. The dosage is likely to be reduced to the minimum effect level to reverse these effects, and very slow and careful changes in dosages are made as necessary to avoid over-medication. Monitor all patients closely for behavior changes because these drugs can exacerbate depression and psychosis. Report abnormal involuntary movements such as chewing, grinding of the teeth, protrusion of the tongue, repeated opening and closing of the mouth, head bobbing or jerking, constant movements of the feet or hands because these can indicate dystonia, which can be related to progression of the disease itself or wearing off of dopamine. If these symptoms appear, alert the healthcare provider because the drug dosage may need to be adjusted. The expected evaluation or the expected outcome would be the resolution of the Parkinsonian signs and symptoms, decrease in tremors and rigidity is an important part, improvement in gait and balance. The therapeutic effects are usually seen within 2 to 3 days after the initial therapy has been started. Catechol-O-methyltransferase, also known as COMT, C-O-M-T, inhibitors, is an enzyme that breaks down or metabolizes naturally occurring catecholamine-based neurotransmitters, including dopamine and dopamine agonist drugs. A catechol-O-methyltransferase COMT inhibitor is a drug that suppresses the activity of the COMT enzyme so that naturally occurring dopamine and dopamine agonists remain active in the body longer, helping to restore the ACH dopamine balance in the brain. Levodopa is the main dopamine agonist drug used in Parkinson's disease. A COMT inhibitor is given with levodopa to allow blood levels of levodopa to stay high enough to enter into the brain, where it is then converted to dopamine. Entacapone, also known as Compton, and tolcapone, known as Tasmar, are COMT inhibitors that are also used for Parkinson's disease. The nursing implications: give entacapone with every dose of carbidopa levodopa to enhance the drug effect. We're talking about giving 2 different drugs here from 2 different classifications to start treating the Parkinson's disease: the dopamine agonist and a COMT inhibitor. Give the first dose of the tolcapone with the first dose of the carbidopa levodopa and subsequent doses 6 to 12 hours later. Review the liver function studies and monitor the liver failure in patients who are taking tolcapone. Report signs of liver failure such as abdominal pain, jaundice, dark urine with nausea and vomiting to the healthcare provider. Remind patients that these drugs may cause a non-dangerous side effect of turning the urine brownish orange color. These drugs enhance the effect of dopamine, and symptoms of worsening dyskinesia or psychosis may also occur. Notify the healthcare provider if these changes occur. These drugs cannot be given with non-selective MAOI inhibitors because they increase the cardiovascular risk. Anticipate that the carbidopa levodopa dose may be decreased as the drugs take effect. The nursing implication and patient teaching: the patient may experience orthostatic hypotension because COMT inhibitors potentiate the action of carbidopa levodopa. Take a full set of vital signs and orthostatic blood pressure levels, which also means the blood pressure and pulse both have to be taken while the patient is in a lying position, sitting position, and standing position. And remind patients to rise slowly to avoid falls. Monitor for indications of dyskinesia and hyperkinesia, and notify a healthcare provider if they occur. The planning and implementation of entacapone is given with every dose of carbidopa levodopa. Tolcapone is given with the first dose of carbidopa levodopa, and subsequent doses are given 6 to 12 hours later. If tolcapone is used, monitor patients for liver failure and review liver function tests. Entacapone is given with every dose of carbidopa-levodopa, and talcapone is given with the first dose of carbidopa-levodopa and subsequent doses thereafter. The expected side effects and adverse reactions of entacapone and talcapone can potentiate the dopaminergic adverse effects of levodopa and cause dyskinesia and hypotension. The most common expected effects are GI upset and discoloration, the brownish orange color of urine. Both drugs are metabolized by the liver, but tolcapone leads to a higher risk of severe liver failure, and it is not used unless other measures have failed. Tolcapone is not used in persons with existing hepatic disease. The liver function must be closely monitored every 6 months if tolcapone is used. The drug interactions, neither entacapone nor tolcapone should be taken with other MAOI inhibitors such as phenolazine, also known as Nardil, because they reduce the catecholamine metabolism and can cause cardiovascular problems such as severe hypertension, tachycardia, and dysrhythmias. Likewise, any direct catecholamine drugs such as epinephrine or methyldopa may increase heart rates, cause dysrhythmias, and lead to severely high blood pressure levels. The MAO-B inhibitors, selegiline, known as Aldopril, and Zalapar, and razagiline, known as Azilect, used in patients with Parkinson's disease, are considered safe to take with COMT inhibitor drugs because they are selective in blocking the breakdown of dopamine, but not other catecholamines, and the adverse cardiac effects are avoided. Evaluate patients for akinesia, dystonia, and tardive dyskinesia, because these drugs are given with carbidopa-levodopa and increase the response of dopamine agonists. Monitor patients for depression and psychosis. The expected evaluation and the expected outcomes are the resolution of Parkinsonian signs and symptoms. Another classification is monoamine oxidase type B inhibitors, MAO-B inhibitors. They allow existing dopamine to remain active in the brain longer by inhibiting MAO-B, which breaks down dopamine in the brain and elsewhere in the body. Rasagiline, also known as Azilect, and selegiline, known as Aldopril. MAO is made in the mitochondrial membranes in most cells of the body. The enzyme breaks down or metabolizes many substances. The MAO type A breaks down many neurotransmitters, including epinephrine, norepinephrine, serotonin, and dopamine. The MAO type B is more specific for metabolizing dopamine and serotonin. The monoamine oxidase type B, MAO-B inhibitor, suppresses the action of MAO-B, which allows dopamine levels to increase and reduces the symptoms of Parkinson's disease. MAO-B inhibitors are sometimes used to treat depression because this drug category also reduces the breakdown of serotonin. These drugs have fewer side effects than MAO-A inhibitors, which are non-selective. 3 MAO-B inhibitor drugs, selegiline, rasagiline, and sulfonamide, also known as Oxadogo, are used in combination with carbidopa-levodopa. They typically are used earlier in the disease course as monotherapy or in addition to dopamine agonist drugs. Adding MAO-B inhibitors to the drug regimen allows the dose of levodopa to be decreased, which lessens the side effects of higher levodopa levels. The nursing implications are to give these drugs at the same time every day. Once a day doses can be given at nighttime because they can cause drowsiness. Teach the patients to avoid foods and beverages that contain large amounts of tyramine. When using any of these drugs and for 2 weeks after therapy is stopped, monitor vital signs, particularly the blood pressure. Teach patients and families to report severe headache, palpitations, nausea, and vomiting to the healthcare provider immediately because these are the signs of hypertension crisis. These drugs enhance the effect of dopamine, so symptoms of worsening dyskinesia or psychosis may occur. Teach patients and families to notify the healthcare provider if the changes occur. Anticipate that the healthcare provider may decrease the dosage of carbidopa-levodopa as these drugs take effect. The patient and family teaching. These drugs can take several weeks to begin working. Do not exceed the prescribed drug dose because doing so can cause dangerously high blood pressure levels. Avoid foods that contain tyramine, such as beer, red wine, aged cheese, smoked meat, cheese, fish, soy products, and pickled herring. Report symptoms of very high blood pressure, which may be headache, irregular pulse, nausea, vomiting, to your healthcare provider immediately. Very low blood pressure symptoms may be dizziness, lightheadedness, fainting are possible, so move slowly when arising from a sitting or lying position. Do not take over-the-counter drugs or herbs without checking with your pharmacist or your healthcare provider. These drugs cause drowsiness. Avoid driving or using dangerous machinery until you know how the drug affects you. Wear sunscreen, sunglasses, and protective clothing when outside because this drug increases the risk of serious sunburn even if you have dark skin. The assessment is monitoring the vital signs, especially during drug dose increases. Alert the healthcare provider for any changes, especially in blood pressure and pulse, because orthostatic hypotension, hypertension, or tachycardia with new dysrhythmia may indicate adverse reactions to the drug. Monitor all patients closely for behavior changes because these drugs can cause hallucinations, delusions, depression, and or confusion. Some foods that contain tyramine are cured or smoked meats, fish and cheeses such as salami, anchovies, avocados, bananas, figs and raisins, beer and red wine, sauerkraut, sour cream, soy sauce or soy-containing foods such as miso soup, yeast extract found in some breads, canned foods and snacks, yogurt, and pickled herring. Some expected side effects and adverse reactions. The usual side effects of MAO-B inhibitors are dry mouth, nausea, constipation, and lightheadedness. Confusion and hallucinations can occur, especially in older adults. The adverse effect of severe hypertension can occur, if MAO-B inhibitors are used in high doses, but this is unlikely to occur at low doses. Thiamine-rich foods should be avoided when taking MAO inhibitors because they cause a severe hypertensive crisis. In your book, there is a partial list of foods that are available for patient teaching to help the patient avoid when they are taking an MAO inhibitor. Photosensitivity can also occur and increase the risk of sunburn. These drugs, of course, can cause drowsiness. The drug interactions for MAO-B inhibitors interact with some opiate drugs used for pain, such as meropenem, tramadol, and methadone, and can cause a hypertensive crisis as well. They should not be used with droperidol or cyclobenzaprine. Taking MAO-B inhibitors with tricyclic antidepressants, such as amitriptyline, with selective serotonin reuptake inhibitors such as fluoxetine, or with other MAO inhibitors can cause hyperthermia, tremors, seizures, or delirium. Drugs that stimulate the sympathetic fight or flight nervous system, such as amphetamines, phenylephrine decongestant, or dextromethorphan cough medicine, can cause a hypertensive crisis. Ginseng, ephedra, mahog, and St. John's wort can also cause hypertensive crisis and should be avoided with MOA inhibitors. Evaluate patients for akinesia, dystonia, and tardive dyskinesia because these drugs are given with carbidopa-levodopa and increase the response of dopamine agonist. Monitor the patients for depression and psychosis. The evaluation and expected outcomes is that the resolution of Parkinsonian signs and symptoms would be resolved, usually reaching the therapeutic effect within 2 to 3 weeks after the initiation of therapy. The Parkinsonian tremors and rigidity would improve, as well as the gait and balance.